Yeah, I'm a psychiatrist, and I'm interested in the influence of childhood abuse on the development of the brain and also the development of mental and physical disorders. And most importantly, we are studying how this knowledge can be used to leverage and to improve therapeutic aspects in treatment survivors of childhood abuse. And to begin with, just wanted to mention that I will talk about self-injurious behavior. I will show one or two pictures of scars, not very explicit, but just to mention it beforehand. So Her Majesty has already mentioned that we have a pandemic of adverse childhood experiences. About 20% of girls and 10% of boys worldwide are victims of severe adverse childhood experiences. And what is important, that this has massive influences not only on the brain, but also, of course, of the development of mental disorders. For example, here you see typical disorders that are developing. You don't see the pointers. Post-traumatic stress disorders is a prominent example, but also personality disorders and affective disorders. But what is also very important is that also somatic conditions such as diabetes, obesity, or other medical conditions such as ulcerative colitis have increased risks following childhood abuse. So it has influence on the whole body, not only on the brain. And what is also important is that the influence of different types of trauma are sometimes very different. Here you see laid out between different types of abuse and neglect. On the upper left, there's neglect, deprivation, and we heard about that before. And deprivation leads to, for example, to a reduction of the brain, the cortical thickness. In terms of development of mental disorders, it has an influence on externalizing psychopathology, such as in attention deficit disorder. And in the field of somatic medicine, it leads to inflammatory bowel disease. There's a contrast to the influence of physical or sexual abuse, which you see on the lower right. Here, abuse, for example, is related to a reduction in the volume of the hippocampus, a very important brain region for memory. And in terms of psychopathology, mental disorders, it is related to anxiety disorders. And coming back to somatic medicine, the cardiovascular system, the heart is influenced by abuse more than by neglect. So you see a differential effect of the type of traumatization. Just to give you an example that it covers a lot of different fields, we did a study in women giving birth. And here's an example of how pain sensitivity developed before and after birth. You see the gray line going up. That means that after birth, after a woman has given birth, pain sensitivity is reduced. So women become, if you will, hardened to further pain after birth. That's a natural, I think, evolutionary development. Interestingly, this was not the case in a group of women that had been traumatized. That's a red line. They don't show this normative effect. And this has not only massive effects on pain sensitivity, but we also found that traumatized women that had suffered from childhood sexual abuse, have more fear of delivery, have more pain, particularly back pain during pregnancy, and altogether have a less positive subjective experience of childbirth. And that's prompted us to develop, very practically, to develop special birth preparation programs for traumatized women in Mannheim. Not only the type of traumatization is of importance, but following up on the previous talk, the timing is of utmost importance. We heard about critical windows in brain development, and we exactly found that in studies that we did in traumatized women and men with different mental conditions, we assessed retrospectively abuse and neglect experience, and what we found is what Professor Singer mentioned. There is a critical period, not only in the early age, it's hard to see, but on the left side it's ages 3 and 4. So when abuse happened to children at the age of 3 and 4, it has a massive influence on the volume of a brain region that is shown on the upper right, the cingulate cortex, which is very important for emotion regulation. On the other hand, in a later period, in adolescence, age 15 or 16, there's also in the second critical period. And the same is found when you look at the functional activity of a region, the amygdala, that is shown the red dot in the middle. This is our emotion center of the brain. Here again, when abuse happens very early in age 3 and 4 and later in later adolescence, as mentioned earlier, this is important for the activity of this region. So we see that the brain has sensitive or critical periods. And this is, it's not surprising, that is similar to what was also shown by Professor Singer. Not only schizophrenia, but most severe mental disorders start in adolescence. You see here schizophrenia, mood disorders, personality disorders, basically all important mental conditions start in that age period between age 10 and 25. Coming now to self-injury, which is an utmost example of this phase of transition. You see the typical behavior, cutting your arms with razor blades. It's a very frequent behavior. You see it peaks in adolescence here, age between 15 and 17. About 20 to 25% of young people have experienced that, have done that before. This is really a strong number. And when you talk about self-injury, let me just give you an overview what that means. We differentiate between suicidal behavior on the left. So if you intend to take your life, that's suicidal. But you have on the right side, you have what we call non-suicidal self-injury. So people cut into their arms or legs. They don't want to kill themselves. They just want to reduce their very hard levels of stress and affective arousal. And unfortunately, it helps very well. Self-injury, that's what we are talking about. It's a form of non-suicidal problematic behavior. And it's indeed very frequent, showing again numbers here from different European countries, France, Germany, Estonia, but you find the same numbers in other continents. As I said, about 20 to 40% have done it once. But the important thing is on the right. About 10 or even a little bit more percent of young girls, women, have done it repetitively, so more than 5 times. So they stick to it because they learn it helps. That's a problem, and it is closely related to adverse childhood experiences. You see that here in this analysis, different types of adverse childhood experiences, such as problems of neglect, physical or sexual abuse, increase the prevalence and increase the risk for self-injurious behaviors. And now coming to social media and problems related to that, there is something what we can call a social contagion. NSSI, non-suicidal self-injury, can be triggered by peers in real life, but of course also in the virtual reality, in virtual life. This is, for example, pictures from Instagram. There are forums exchanging pictures and statements. This person here posted a statement when I just wrote about how I was feeling. Nobody was interested. As soon as I posted these pics here of these cars, people started commenting. So they are getting attention. Somebody cares about them. And here's an interesting study from what the comments actually were on Instagram. So about, you see the left bar, there was a lot of general discussion, but what is more interesting is what there were some empathic comments. About 24% of these pictures received comments like "stay strong," "keep on," "get help." Then there were some warning comments like "stop distributing self-injury," so they didn't want to see that. But there were even helpful comments like, "if you need someone to talk to, I'm there for you." But what I think is also very critical is that there are also abusive comments. So stuff like, "you are too stupid to find an artery," for example, very abusive, obnoxious comments that are posted in these Instagram forums. Only few responded and commented the positive feelings about the scars here. Coming to social media and self-injury, this is a large meta-analysis. There is, of course, and we heard about that this morning, there is a strong influence of cyber-victimization and self-injury related media use on actual self-injury. So the more you are victimized in the internet and the more there is more media use related to these contents, the more you really do that in real life. Interestingly, there is no influence of general social media use. So just the using social media doesn't seem to increase the risk. It is the particular related content related to self-injury or to cyber victimization. And I assume Professor Montag will talk about similar things and more about that in detail later in his talk. Okay, coming to treatment, which is really important. So in most countries, at least in European countries, we have the opportunity to treat most mental disorders effectively during this critical period. So we should start treatment early in this critical phase during adolescence. We are able, and that's our advantages. We have early diagnosis. We know how psychotherapy works. We have effective psychotherapy. We include families, and there are in various countries there are opportunities for community mental health. But there is a problem, and not only in poorer countries, but also in our countries, many current mental health systems do not allow effective treatments of this critical group. Why is that the case? Let me just give you an example, because a lot of young people that start, for example, self-injurious behavior, they don't find a psychotherapist. That's a problem, not only in Germany, I guess worldwide. There are not enough psychotherapists, psychiatrists that treat these young people. That leads to increasing numbers of crisis intervention, in hospital admissions, repeated stays in psychiatric hospitals, and this is in a kind of a vicious circle that leads to a reduction of normal peer behavior, that leads to a reduced reduction of school visit, problems with interrupted occupational training, and so on, and they don't start their normal adult life, and in adulthood they start this psychiatric career again. They have to go to crisis intervention over and over again. That is a problem. It's a kind of a vicious cycle, and that was the reason why we started what we call an adolescent center. It's a treatment center. Here is a picture of our treatment center in downtown Mannheim in Germany, where we have that all under one roof. We have a large outpatient facility where we can treat young people between the age of 15 to 25, not only in presence, we also do online therapy. We started that during the pandemic, and that is sometimes it's very helpful and doable. I have a longer outreach. We have diagnostics. We have group treatments and so on. And we also have the opportunity to do residential and day hospital treatment all in the same building. And of course, very important is that we collaborate with other networks, educational networks, assisted living, and schools and welfare systems. How does that treatment look? We treat traumatized adolescents starting at age 15. What is very important, besides the regular psychotherapy, is to include carers and significant others. We do that by consultation. We have regular workshops, 2-day workshops for the families of these adolescents, and they can bring their families, but also their peers. This is very helpful, and we focus on this problematic behavior, of course. We focus on self-injury and affective dysregulation, not only in the hospital, but also in their home environment. And they are enabled to visit school during treatment, and also to do occupational therapy and internships. And very important is a therapy element, experiential education, where for example, canoeing tours or climbing exercises. And that this is effective, you can see here on the right, the dark brown bars on the dark brown bars are the effect sizes that are for this treatment. You see effect sizes from 1 to 1.6, and you probably know that effect sizes above 0.8 or 1 are very high effect sizes. And the nice thing here is that the effect sizes are even higher than when you treat later. So the earlier you treat these traumatized people, the better the effects are, which is of course understandable, that it's that the earlier the treatment happens, the better the effects are. But a lot of people are hesitant to treat adolescents or even younger people with trauma. They say we have to wait and stabilize for years and so on. But our experience is you shouldn't wait too long. You should start treatment very early on. Coming to the end, I'm not an AI expert, but we start using AI and want to also show a positive side of how AI can be used for therapy. Smartphones have already been used for several years in therapy. Now we use speech samples, so recorded speech samples of these traumatized adolescents to analyze their thoughts and their emotions, and then that this simply shows that it's highly accepted. Sorry, you can't read it from here. They like it. They are happy to use that. Of course, they are used to smartphones, but they also like to include it into therapy, and it's well accepted. And now we can use AI to generate feedback and also to choose feedback that has been generated to users that is not a replacement of psychotherapy, but of course some kind of an addition to regular psychotherapy. And we hope that we can use smartphones and AI in the near future to assess symptoms and also to improve therapy for patients with these trauma-related disorders. And with this, I would like to thank you very much, and I hope I haven't spent too much time. Thank you.